Good afternoon and welcome to today's Link Senior webinar. Just a few housekeeping items before we begin. Today's webinar is only providing one NCAP CEU credit. There will be no NAB credits given for today's presentation. To be eligible for this NCAP CEU credit, you must stay on the webinar for the full hour today. At the end of the webinar, I will provide the required post-webinar survey evaluation link, both in the webinar room chat box and also by a constant contact email message that will be sent out after the conclusion of the event. You must fill out the required survey if you want your CEU credit no later than midnight this Thursday, February 14th, to be eligible for your CEU credit. Certificates will be sent via email on Friday. If you are not looking for CEU credit, please do fill out the survey as well. We would like your feedback. The PDF of today's PowerPoint deck is in the handout section of the webinar room, along with 2 additional handouts from our speakers today. Link Senior started providing monthly educational webinars last year, and we have had more than 4,000 people participate since that time. At the end of today's webinar, we will also be sharing a list of the upcoming 2019 speakers. Here is a look at just some of the speakers from last year. We are always looking for new ideas on both webinar topics and potential speakers. So we've provided an email address on this slide where you can send us your thoughts and ideas. Link Senior currently has more than 300 clients in the US and Canada, and this is just a snapshot of some of our current partners and supporters. The preliminary results of our most recent research study at 3 long-term care and memory care communities in Toronto show that being highly engaged in recreational activity is associated with increased cognitive functioning and social engagement, as well as decreased aggression and antipsychotic medication use. This work was generously funded by the Baycrest-led Center for Aging and Brain Health Innovation. Today, we are excited to have Dr. Katie Abbott with us. Katie is an assistant professor of gerontology at Miami University in Oxford, Ohio. She is currently working with the state of Ohio, where the Preferences for Everyday Living Inventory, or PELI, has been mandated for the use in the state's 960 nursing homes. Katie is joined today by Dr. Kimberly Van Heidsma, an associate professor at the Pennsylvania State University College of Nursing. Kimberly's recent work is focused on the goal of having care delivery to older adults be configured around their preferences. We also have Charles Morin with us, the CEO of Link Senior, and he will be talking about today's agenda and objectives. Please remember we are reserving time at the end of the webinar today for your questions, which you can post in the chat box. Charles, I'll let you take it from here.
Thank you so much, Megan. It's a great pleasure, and I'm actually very excited that we can bring you today 2 of the top experts in the field of aging and engagement, not only of their experience and work, but also the research that they've been conducting. What I suggest is that we start a little bit by understanding why are we here and focusing on some of the key elements that we see today on February 12, 2019 when it comes to resident engagement. And so I will be providing a couple minutes introduction, and then letting our keynote speakers do their presentation. So why is there a need for better resident engagement? I think that it's worth asking the question, especially in the context of person-centered care. Some of you might be familiar with the work of Dr. Abraham Maslow. He came up with the pyramid, the hierarchy of need. But he was also famous for helping us understand and helping us make sure that we know that each person is a person throughout their stay with us in senior care, regardless of who they are and why they're here until the very last moment. And I think it's important to remind us that we can help the older adult find purpose and meaning in their lives. That is our role today. we sometimes forget a little bit that when it comes to this clinical or healthcare approach that our industry has, Dr. Jiska Cohen-Mansfield is famous for having done a lot of the groundwork. And she defined the idea of engagement by what we can do to provide occupation and stimulus. But there is something missing here, which is this idea that regardless of who we are and why we're in senior care, we need meaning and purpose. And the reason why we thought it was important to highlight that is that the work that is going to be highlighted today, the work that is going to be shown today, are tools that help us understand how we can help the older adult find meaning and purpose throughout their stay with us. Why is resident engagement so challenging? If you've been to some of our webinars, you've probably seen some of these slides, but we think it's extremely important to understand why are we challenged in providing better care, better person-centered care, and better engagement. Regardless of the staffing aspect, which is challenging, we often forget that the older adult under our care need us. This is exemplified by the fact that a lot of them have cognitive impairment or diagnosis of dementia, such as Alzheimer's. And we sometimes often forget the fact that, sadly, the family doesn't visit the older adult, which means that they are reliant on us, the staff, often the frontline staff, to stay engaged, to find their meaning and purpose. The other aspect, which is very important, is that there is a big focus, as we know, on the reduction of antipsychotics drugs. But we often forget the fact that medicating the older adult actually creates an additional challenge. If an older adult is receiving some kind of antidepressant or some kind of antipsychotic, it will make them harder to engage, therefore making our task more difficult. What is the result of all of that? It is actually, if you look at it from one angle, pretty sad. There's a CDC report that was released in 2015 that shows that in long-term care, in a skilled setting, a resident gets 11 minutes of activities per day. And in assisted living, it is slightly more. It's 20 minutes, right? And so one would argue that this is a sad standard. We actually are very, quote-unquote, excited when we see this, because this means that we have a lot of potential, a lot of opportunities to increase the quality of the life of the older adult if we were able to provide more programs that are more person-centered. One would ask the question, how can we do this? It's important to remember what we are trying to do. An activity director, somebody working in life enrichment, in wellness, or rec therapy should and is trying to get to know the residents, to be able to plan, to engage, and evaluate. Understanding these core needs of resident engagement helps us understand what are the challenges. One big challenge these days is staffing, so there is a big need for efficiency. And I'll use this efficiency and need for evidence-based to discuss why we selected these speakers today. A lot of their work is driven by this idea of finding evidence and best practices when it comes to engagement and preferences of the older adult. And we thought it was a great way to help us understand not only what does research tell us when it comes to evidence-based programs and avenues to help us engage the resident, but also if we were to be efficient, we would need to understand what would be the top preferences across the long-term care setting. So this is a way for me to introduce Kimberly and Katie today, and I'll let Kimberly start with her presentation.
Thank you, Charles. I appreciate that. Wonderful setup for me going forward. So if we could have the next slide. So I just want to, before we get started, acknowledge that, the generous support of many of the funders that you see listed here that have supported this work over many years. Next slide. So as Charles mentioned, this context that we're working in terms of trying to understand better issues related to what comprises person-centered care. And as Charles so eloquently talked about, the time crunch that is endemic across all settings of care. So the goal of facilitating engagement, purpose, meaning is facilitated. One way of starting that is to facilitate it through looking at what are the top preferences that people have that we care for, that we serve as a beginning point for us to say, if we got to start somewhere by expanding out of those 11 minutes, making it 12 minutes, how do we use that extra minute that we're going to use? Where should we focus our attention? Well, we should focus our attention on what matters most to the people that we serve. And one proxy for that is learning what their preferences are and then starting with that top preference. So we're going to examine through the research that we did what the older adults themselves told us in terms of what their top preferences were. And we're going to look at it in a couple of different settings of care. We have one aspect of the study that was done in home and community-based settings, and another that was done in residential and nursing home setting. And again, our goal in doing this study was to really look for a signpost for organizations who are seeking that, what am I going to do with my one extra minute of time to increase that positive, engaging moment with that person that I'm providing care to. All right, next slide. So as Charles pointed out in a slightly different way, the graphic that he looked at from assessment to equality engagement, this is just a slightly different way of looking at it in terms of how we think about using our knowledge about people's preferences to enhance quality care delivery. So that first step, of course, is learning about what preferences are important to older adults, and we'll give you a little bit of a hint as to what those top 10 might be. But then, of course, we need to do something with those preferences. So other areas of our work really look at enhancing approaches to fulfilling those preferences and then developing a quality assurance and performance improvement plan around them. But we're really going to focus on that step one in the process today. All right, next slide, please. So the Preferences for Everyday Living Inventory was a instrument that we've been working on for about almost 20 years now. And its origin really came in this idea that we were interested in customizing, individualizing, personalizing care to older adults. So this is not a new concept. But what we found, much to our amazement when we first started working in this area, was that there was very little work done in terms of systematic assessment in this area. Everybody seemed to have a way of asking preferences. There was an understanding that it was important to ask, but there wasn't any really rigorously developed tool to accomplish that goal. And so we set about designing the Preference for Everyday Living Inventory, which we lovingly call PELI for short. So this is an example of the very first page that asks, how important is it to you to choose what name you would like me to use when I greet you? And then if the older adult says that it's important to them, somewhat important or important but can't do, we then go into asking them more detail about what name would you like me to use when I greet you and document that for the notes. If it's not important, then we simply go on to the next question. So it is designed to have skip patterns and be efficient in terms of the assessment process. Next slide, please. So there are 72 items in all on the inventory. It's quite comprehensive. And again, this was designed with asking older adults to tell us what's important to them. So these 72 represent the range of things that they told us from the time they woke up in the morning till the time they went to bed at night. It does assess the importance of those of a range of preference domains, and you see the domains there. Everything from who do you want to have social contact with? So how important is it to you to spend time one-on-one with someone would be an example of that type of question. To growth activities, which personify, the ongoing need to learn new things, be engaged in new things in your life, even as an older adult. That need doesn't go away. To leisure activities and recreational preferences, such as the one example you see here, which is to be involved about cooking. And of course, self-dominion, which is the need for autonomy and choice in how you actually choose to go about living your daily life, and the example item here, and choosing how to care for your hair. And then also, of course, some reference to something about the caregivers and the care that you would like to receive in terms of an example of whether your daily caregiver is male or female. So this just gives you an example of those 72 items that you would see on this inventory. Next slide, please. So as I mentioned, the tool was developed in concert with older adults. It's phrased in clear conversational language, and it really is designed to help staff use this questionnaire to learn about preferences with those other goals of not just assessment, but personalizing and improving care. Next slide, please. So I think I already mentioned that, much of our work has included studies on how to incorporate resident preferences into that next step of quality care planning and quality improvement efforts. The Peli items were also used to contribute to the development of the MDS 3.0 Section F, which is a required section for all nursing home residents. So those 16 items are fully incorporated into the Peli, so that it's seamless in terms of what you would already assess in nursing homes, those 16 required items, and then the additional items if you would want to go beyond the MDS preference items that are already mandatory. We do have over a dozen peer-reviewed articles at this point, and as I mentioned, funding from multiple sources. Next, please. All right, I think I already covered this, so next one, please. All right, so now let's talk about some of our research, just to give you a flavor of how we went about learning this information. So we did have 2 different samples of older adults, 255 of which were living in the nursing home at the time we were involving them as research participants, and 528 which were in home and community-based services. And we did have all respondents ask and respond to all 72 items. Next, please.
Want me to take it from here, Kimberly?
Yes, ma'am. You go for it.
All right. Thank you. So hi, everybody. This is Katie. And I'll tell you a little bit more about the methods of the study that we're going to share with you today. So as Kimberly mentioned, we have these 2 samples. And I want to tell you a little bit more about the samples. So home care participants were selected from the Visiting Nurse Service of New York's client base. And participants were deemed cognitively capable to participate by passing the Orientation Memory Concentration Test. And after they were assessed and deemed eligible, home care participants were interviewed in their homes by trained research staff. And similarly, the nursing home sample was collected through a convenient sample of 28 providers in the greater Philadelphia region. And the social worker in each site identified individuals who were English speaking with a many mental state exam score greater than 13, and with a planned stay, with the thought that they would be a long stay resident, and that they had lived in the community for at least 1 week at the time of the study. The full study that we're not reporting today, we actually followed individuals for 3 months and asked them their preferences again 3 months later. And as in home care, research assistants conducted face-to-face interviews using the Peli in the nursing home, And one important point I want to mention, Kimberly showed in the Peli sample that there is this option of important but can't do or no choice. That option was not offered when we did the study because of the research, of the nature of the research. Next slide, please. I want to tell you a little bit about the demographic characteristics of the participants. And so in the first column there, you'll see our nursing home resident characteristics, and then the next column, the home and community-based or the home care clients. So the home and community-based participants, on average, were about 77 years of age. They were female and Caucasian. They had achieved about 11 years of education, and 10% were Hispanic. 50% were widowed, and 43% had been receiving home care services for more than 120 days. And then if you look at the nursing home sample, they were, again, predominantly female, Caucasian, widowed, and 75% had a high school diploma. The average MMSE score was 25, and they had been living in the nursing home for an average of 924 days. And when we look at these comparisons across the sites, we do see some statistically significant differences between the samples. So for example, the nursing home sample was on average older than the home care sample, and the home and community-based sample had a greater percentage of Hispanic and female participants. The nursing home sample had a higher percentage of not married and high school degree completion than the home care sample, and there were no differences by race. So next slide, please. So again, as Kimberly mentioned, we wanted to understand, if we look at these two groups, what are the top 10 preferences across both of these settings? Can we even compare them? And so when Kimberly mentioned that there were 72 items in the full Peli, there were not 72 items for us to directly compare. And so the home care and the nursing home Peli versions differ slightly. And so we had 41 items that we could use for comparison across the two settings, and because they were asked of both participants. Next slide, please. And so here is one of the handouts listed here. We're going to tell, this handout is available for you to download, and I'm going to tell you a little bit about the research, and Kimberly will go over the recommendations. But know that you can access this on our website via PreferenceBasedLiving.com. And next slide. So our work suggests that the top 10 most important preferences, and these are endorsed by 75% or greater of the samples, fall into three major domains. You remember Kimberly showed that we had 5 major domains of the Peli earlier. But social contact preferences, such as regular contact with family and friends, privacy, and giving gifts, which surprised me when that came, from our data. And so one of the other handouts that we've provided are tips for honoring the preference of giving gifts, because I think it's easy for us to think that this is sort of just something that's not really necessary, but it's very meaningful to individuals, and they tell us that it's a strongly held important preference. Then we also see leisure preferences, such as listening to music, spending time outside, and that self-dominion or autonomy, such as choosing what to eat and when to bathe. And so what we want to have as our take-home message here is that when you are in doubt, starting with the goal of fulfilling these 10 preferences may be a very productive way to focus your initial efforts in terms of preference fulfillment. Next slide, please. I'll show you a little bit of data, and excuse me, don't let your eyes glaze over. We won't spend a lot of time here. So again, among those 41 shared preferences, there were 10 that 75% or more of both samples reported as important. So here's the top 5. And so what we see here is that the number one important preference across both samples is having regular contact with family. And as Charles mentioned, family may not always be nearby. They may not always be available to visit. But this is, if there's any way that you can encourage family to engage through technology potentially, this would give you a very big bang for your buck here. In terms of looking at some of the other preferences, you'll see that listening to music is number 3 for the nursing home and number 5 for the home and community-based sample. You can see having contact with friends is number 3 on both. It's just offset a little bit because we had a tie for number 3 in the nursing home. And privacy, you can see is number 5 for a nursing home sample and number 4 for the home and community-based sample. So next slide, please. Here we'll see preferences ranked 6 through 10. And again, what you see here is that in the nursing home, going outside for fresh air, this one was number 2 for our home and community-based sample. Here you see giving gifts, right? Numbers 7 and 6 relatively. Choosing what time of the day to bathe or taking a specific shower, that's 8 and 10 for nursing home and community-based. And then watching TV is number 9 for home and community-based, but it was number 4 for the nursing home sample. Next slide, please. So again, to sort of in summary, these 10 preferences were rated as important, and what we really want to have as a take-home message is that more than 90% of respondents in each group rated having regular contact with family as an important priority. Having privacy, choosing what to eat, when to bathe, as well as having activity options were also important preferences in both groups. Next slide. And so what I also want to highlight is that, again, we had those 41 shared preferences, but we also had the remainder of Peli items that didn't match. And so what I want to tell you a little bit is when we just look at the top 10 unmatched items, we see a little bit of difference in each setting. And so next slide, and I want to tell you in the nursing home sample, and these questions were not asked in the home and community-based sample. So we asked about how important it was for staff to show you respect, have staff show they care about you, choose who you would like to have involved in discussions about your care, and choose your medical professionals. These were also top preferences just in the nursing home sample. And again, purely because they were not asked in both samples. Personal care, how to care for your mouth, and how frequently to bathe came up for the nursing home sample. Aspects of their environment, such as taking care of their belongings or things and keeping their room at a certain temperature, was an important top 10 for just the nursing home sample. And then the final item here, emotional concerns. So doing what feels better when you're upset was important for nursing home residents. And then the next slide. And then if we just looked at the home and community-based samples, top preferences, we saw a lot of information about activities. So spending time outside, being active at certain times of the day, music, again, giving gifts, traveling, and then aspects of their environment, privacy, keeping possessions in a certain place, and then meals, choosing what to eat. So we've had people tell us, please don't dust my angels. I really, that's something I want to be able to do. So thinking about their possessions in that way. And so now I want to turn it back to Kimberly. You can go to the next slide, who's going to start to talk to us about what all this means.
Oh, thanks, Katie. One more slide progressed, please. So before I sort of dive in, I wanted to show this picture of Pinky. And this is to illustrate that we know, of course, that not all preferences are created equal in terms of their ease of meeting them. And so Pinky reminds us that her love of chickens is a pretty unique preference and didn't make it to our top 10, but this particular care community she was in found a way to meet this very difficult preference. So again, it can be done, but of course not all of them are easy. So let's advance the next slide and look at some of the recommendations. So as Katie mentioned, that the top 10, as well as the sort of site-specific top preferences, serve as a role of focusing organizations on opportunities to address their most important preferences first. And clearly, the theme of connecting with family and friends, whether that be through visits, emailing, letter writing, video opportunities, other types of connection opportunities are really, really the theme that we hear throughout both of our samples that we were looking to ask what was important to them. But other priorities might include for the organization to think about preferences for related to meals or activities such as spending time outdoors, the enjoying music or creating those small gifts that people can provide to other people, as well as opportunities to maximize privacy and choice in various daily types of activities and focusing around bathing. So again, any one of these might be a great starting point for an organization to select to begin working from a quality perspective around. Next slide. Again, this is just a reminder of, in short form, the order of the preferences that were in their order of priority. And just the emphasis being that not all 10 can be necessarily the focus at the same time, but selecting anything from this list would be a great way to kick off that additional use of that 1 minute that we talked about at the very beginning. Next slide. So our findings also highlight that there's a lot of diversity. So we presented today, the diversity between settings, that there is some variation. But of course, when we get down on an individual level, there's even more diversity. And the opportunities that presents in terms of exploring each individual's priorities for their life and the need to really customize that care, capture what's that person's preferences are, and also to be aware that sometimes preferences change. And so we have done quite a bit of work on looking at this issue of the stability of preferences over time. And what we find actually, the take-home message there is that more often than not, because they are overlearned behaviors that people have had their entire life, preferences are quite consistent over time. But some of them do change. And so the opportunity to be responsive to those changing priorities and the need for continuing assessment in terms of preferences is not a one and done activity, but we should always be alert to people's change in preference over time. Next slide. So we have found that not just the process of learning about preferences as an aid to customizing care, but just the conversations that are engaged in to get at the preferences of the person are extremely valuable and enjoyed by both the older adult as well as the staff person doing the interview. And we found that these conversations really build and strengthen the meaningful relationship between that older adult and the caregiver, regardless of setting. So all of us, when we feel that our wishes are heard, that somebody really wants to understand who we are, respects who we are, this really leads to a sense of connection, a sense of competence, independence, and quality of life, and engagement in life. Next slide. So in terms of the Peli interviews, helping to focus on that quality assurance and performance improvement initiative, selecting one item, for example, if you selected regular contact with family and spending time outside, you might form a task force around that to explore how well you're doing already in meeting that preference and what are the opportunities for improvement. And then you can track trends over time to see your progress in that regard. Next slide. Now, our study did have some limitations, of course. There is much more work to be done in this area. We did work with older adults who did have the cognitive capability to answer our questions about what they preferred. So obviously, looking at people who are more cognitively impaired, and we have done some work in that area and will continue to do work in that area, is a challenge, as Charles already mentioned. We did find that facilities and care communities were more inclined to refer residents that were capable to participate. And again, as Katie mentioned, that the home care and the nursing home samples, the items that we were using were not exact matches because we were in the process of developing and refining the tool over time. Next slide. All right, I'm going to turn it back over to Katie to talk a little bit about the Pelican Initiative and how you can get more information.
Thanks, Kimberly. So this is just a picture of our team and here at Miami University in Oxford, Ohio. The initiative that we have been fostering here in Ohio is to support providers in their efforts towards assessing and honoring resident preferences. We didn't realize that there was going to be a mandate through the state of Ohio to use the Peli. That just sort of happened, I think, based because of all of the research that we've done. But we didn't think that it was something that providers should shoulder alone, and we wanted to be a part of this solution. We didn't think that person-centered care was any one provider's duty to respond to, that they can be supported. And so we work with providers across Ohio and across the country to develop solutions. And so many of those solutions are on the website, as I've mentioned, and we hear about the good work people are doing, and we try and highlight it and share it. And so feel free to reach out to us. Again, the website, I think if you go to the next slide, I think we might have a slide with here we go. So PreferenceBasedLiving.com is our website. And you can find lots of our resources there. You can reach out to us. If you have questions, we have a helpline. So feel free to reach out. We have funding right now through the state of Ohio. And so we have support for this work. And we do love to engage with providers because you guys are doing the very important hands-on work. And so we want to have your back. And so I think that might be our last slide. Yeah, and there are emails if you want to reach out.
Thank you so much. Thank you so much, Kimberly and Katie, for this fantastic presentation. You know, it's interesting to see research based on, I think that, something that we perceive as mundane in the field of resident engagement, right? Most activity directors know that they have to know the residents, right? That is the beginning. First things first is who are we serving today? But I think that to see research and to understand your work, Katie and Kim, helps us guide our work in understanding what are the best things that we can do to engage the population that we have. This is fantastic and definitely helpful today and tomorrow. So it's really defining the future of our work, of our discipline in resident engagement, right? Regardless of the level of care and whether we are an activity director, a life enrichment coordinator or director, a rec therapist, or even just someone working in the field of wellness. So we do have a few minutes, which is great because we've had quite a few questions come in. And so Katie and Kimberly, I'll just ask the question and then we just feel free to jump in, whoever wants to. I'll just start with one of the very first questions we had, which is kind of simply, beyond your website, how do you get started? Do you have any recommendations for that? Generally speaking, how do you get started with some of your work?
That's a great question. I'll start off, and then Kimberly, you can chime in. And so one of the things that we wanted to do is answer this very question. And on the website, under our tip sheets, you'll see the very first tip sheet is how to get started. And so what we recommend, there's a few different strategies. One, we recommend that you take a look at the full Peli assessment and start to look at the items. What resonates with you and your organization? Maybe what are the things that fit with your mission? What are things where you might know that you have some work to do. For example, in Ohio, we have resident and family satisfaction surveys that are done every other year, and probably without exception, meals and dining is always the lowest ranked item for any provider. And so they come to us and they say, how can we use the Peli to improve our meals and dining experiences? And so, for example, there are 6 food preferences on the Peli, and you can use those items as a starting point if that's an area of focus for you. And then, as I mentioned, we can provide consultation if you want to reach out to us, and we can have, a virtual call and chat with you about some different options and brainstorm with you and get you on your way. So, Kimberly, if you want to chime in too, go ahead.
Yeah, I mean, just to, again, come back to the idea of really making this a part of thinking about this as a performance improvement program. So there's a lot of benefits to that. I mean, within the nursing home setting, there are regulations and requirements for a selection of a PIP, and this is a great one. And it's also one that I think we have found that survey groups with the increasing focus on our organizations meeting and asking about and integrating preferences into care. They love to see the fact that an organization is really taking that seriously and has gone the step of creating a performance improvement focus around that. So again, selecting one of the 10 that we presented here is one way to go. Katie mentioned the idea of within that 10 even saying the mission focus. Another thing is to go, if you're in a nursing home, to think about the items on the minimum data set, which you're already collecting, and really amplifying the use of data that you're already collecting in a meaningful way. So those are all ways to think about how to select which preferences to get started with. But then also, of course, we would encourage organizations to start slow. Start in a small area, select a particular household or care area as the focus, and really work in concert with that interdisciplinary team, bringing the residents, bringing family members involved in the whole process to say, we really care about the preferences of the people that we care for, and so we want your input in this process as well as we move forward as a organic care team with all voices involved in rolling out a very focused and meaningful initiative. So I hope that that's helpful in terms of creating a path forward.
I'm sure it is, and I think that a great question that we had, thank you for this. A great question that we had as a follow-up to this is, does all staff participate in completing the assessment, the tools that you have, or would you recommend it be the responsibility of one particular team or department?
That's another great question. So what I can tell you is what we've heard from providers. And what we've seen through the quality improvement projects that we have hosted through the Ohio Department of Aging is that the organizations that utilize the broadest number of individuals, so that they really think of it in terms of how can dining be involved, how can social work, how can activities, how can housekeeping and maintenance, how do we sort of look at all the different ways we might learn about and honor and assess preferences. Those organizations have better success in sort of changing their culture and orienting towards preferences. When it becomes one individual's sort of role, lots of things break down. That individual might go on vacation. They might leave the organization, unfortunately. There is a lot of turnover in this industry. And so what happens is that then everything falls apart and there's no one there to continue the initiative. And so we have heard from providers that in some places they share the work. For example, activities may ask the activity items on the Peli. Dining may ask about the food preferences. You could even have a volunteer assist, or you could have direct care workers asking about the personal care preferences, so that the people who are actually providing those services are asking about how they would like those services offered or completed. Kimberly, you want to fill in?
Yeah, I mean, I think the only thing I would amplify in what you're saying, Katie, is that, again, we've found that regardless of who gets assigned to ask the question, so I hope you're hearing that there is not one answer to that question. It depends on, what's right for your organization. But regardless of who is doing the interviewing, that there is a need for making sure that those individuals are trained in this process, so that they understand why it's important to ask the question, that they understand what's going to be done with the answers to that question, and that they approach the task without an agenda. So the agenda should be the meaningful relationship development, knowing, understanding more about the person, and for whoever is doing the interview to have that opportunity to deepen their relationship with that individual. So we do have some training materials also available on the website that helps orient people and get them started down the right path in terms of making sure that they don't view this as just another task I have to get done in the course of the day, but that they're appropriately oriented to the real goal of this, which of course is enhancing relationships, enhancing engagement, and increasing the quality of the care.
Great, thank you so much, Katie and Kimberly. One question, actually, very quickly. You mentioned that in the limitation of this work, the fact that respondents could respond, right? I mean, that was part of the work. But as you know, a lot of our audience, they work with people that, for some reason, XYZ, including cognitive impairment, sometimes cannot express their preferences. And we were wondering if you had done any research, or if you had any guesses, would these preferences be significantly different or not, or any direction you might be aware of when it comes to these specific older adults?
Yeah, I can take that. I can start off that one, Katie.
Yeah, go ahead.
So
go
yes,
ahead.
Obviously, within long-term care, we're increasingly seeing people who are more and more impaired cognitively and physically. And so, the challenge of providing preference-based, person-centered care is considerable. So, recognizing that our work has gone on to focus on two different areas. One, the use of proxies, or a family member, friend who might know the person really well and could speak in their stead. So there, the idea is that this family member or friend would serve as the respondent for the Peli items themselves. So they would be asked about the preferences and to say, what do you think? If your mother could tell us, what her preferences are, please answer the question for using her voice, to the greatest possible. So that's one whole line and we've done a lot of work looking at how well proxy respondents do when asked to serve that role. And the answer, again, very bottom line, is that for the most part, they do a pretty good job knowing the person's preferences. But of course, it depends on the quality of the relationship they had, how long if they cared for that individual or not personally. So it does depend on a number of factors. We started off this call by saying that, oftentimes family is not available to the resident. And we've certainly found that connecting with family members can be a challenge just in and of itself. And so we're really back to relying on the staff, the direct care staff who knows that resident the best. And so there, using the staff to help us determine what the resident's preferences may be. We can't necessarily rely on that past history because they just met the person oftentimes. So there we focus on staff's ability, enhancing staff's ability to really read the response, the emotional response, the behavioral response of the resident. And using a very simple technique, which is that if you're seeing a resident engaging in an activity and the engagement is positive, meaning that there is positive emotion present, the person is smiling, the person is reaching out and engaging physically with the activity itself, then you're pretty sure that you're right on the money in terms of this being a preference for that person. Whereas if you're seeing the opposite, which is a negative response, the person responds to an activity with anger or anxiety or sadness, then not so much. You're pretty much getting the feedback that this is not a preference for that individual, and that you probably need to recalibrate in terms of trying something else. So very much the trial and error, which everybody who works in long-term care is very familiar with people living with cognitive limitations. It certainly applies here as well, that we're going to use observational skills to really help us determine whether we're hitting the mark in terms of a preferred activity or a not preferred activity. So Katie, you want to add to that in any way?
No, that was beautiful. I think the only other thing that I've heard you talk about is how the part of the brain that experiences emotion remains far into the course of the dementia. And so it's still a very reliable way to communicate and to read someone. And then also some of our work has also explored assessing preferences with people with mild to moderate cognitive impairment. And we have found that people, even into the middle of the MMSE range, into the, above the 13s, can still tell us what they prefer. You might have to give a little more time. You might not be able to ask 10 questions at once. So there are some changes you may have to make to allow for the response to be given, but absolutely starting with the individual is what we recommend, as Kimberly said.
Great, thanks so much. And actually, your answers were so great that you addressed some of the other questions, especially how we would include the family, what kind of preferences to look for, and in the case of nonverbal cues, how to incorporate other cues. And both of you talked about, just how we would perceive the emotions of the older adult. A very quick question, because I'd love to ask two more questions within just a few minutes here. One is, Kimberly, you talked a little bit about the new survey process. We all know that that's a big change for the people on the line right now, the audience. We have a new survey process with the new rules of participation. Anything that you've heard, seen, or any type of general comments about your work, how we would support some of these new survey methods?
Mm-hmm. Well, Katie, you want to take that because that's sort of right up the alley for what we're experiencing in Ohio right now.
There's so many different ways I can start to answer that. I think in a quick way, what I'd like to say is that across the new surveys, I think we counted that preferences were mentioned over 150 times in the regulations. And so if you can show a way, if you can sort of identify and be able to explain how you are attempting to assess and honor preferences, you are going to be better positioned than people who have no strategy for assessing and honoring preferences. I'll leave it there. Really, you want to chime in?
Yeah. No, that's great. I think that makes your work even more relevant. So thank you for that. I guess the one last question before we head into like closing remarks and so on. Say that we start working with some of your best practices today. We found out and we use some of these things that you've explained us today. Once we know the preferences of the older adult, have you worked or would you be able to recommend how to address the preferences? Are there out there, including your work or other people's work, best practices when it comes to not only meeting the needs, but also the preferences of our residents?
Yeah, so I'll start on that one. It's a big question. The simple answer is yes. I think there's a very large literature out there that talks about the benefits that are accrued when you take the time to tailor and individualize and pay attention to people's preferences. So there's many evidence-based practices out there that are based on that premise. And then I'll let Katie give you an example of one, though, that we have been using that really helps the process of communicating those preferences, because I think one of the issue in terms of delivery that we have found is, how do you get everyone on the same page in terms of knowing, all the caregivers knowing what the preferences are. So Katie, you want to describe the PAL cards a little bit?
Absolutely. So again, all these resources are on the website, and you can email me if you have any trouble finding anything. I can direct you. So PAL cards stand for Preferences for Activity and Leisure, and we developed this collaboratively with our Ohio providers, who basically said, okay, we got this assessment down, but we're not successful at communicating these important preferences across different staff, different shifts, different care team members and volunteers. And so the PAL card is a way to just visually represent 6 or so important preferences related to activity and leisure, so that we're not worrying about any kind of HIPAA violation. Every HIPAA privacy officer we've spoken to has said that, having someone's preferences are not healthcare, that you're not violating any healthcare privacy laws by making sure that some preferences are available. And so these cards are placed with resident consent on their walkers and wheelchairs. You can see examples on the website. We've got a whole training, whole pack on PAL card resources where you can download templates that you can fill in information. You can watch little videos on how to use the materials. And again, happy to help that. We've worked with over 30 providers in Ohio to create over 600 PAL cards for residents, and have heard fantastic results in terms of building relationship, building community, and cohesion in communities.
Thanks so much, Katie, and thank you, Kimberly. We're going to just wrap up the webinar today by outlining the upcoming Link Senior webinars for this year. A note that our next webinar is happening Tuesday, March 19th at 1 p.m. Eastern Time. This is going to feature Dawn Worsley. She's the president of the National Certification Council for Activity Professionals. And Dawn is going to speak to us about how the rules of participation are driving person-centered engagement. For this webinar, we will have both NAB and NCAP CEUs to be offered to participants. I have just put the mandatory evaluation link in the chat box. I will also be sending out that evaluation link for those who want CEU credit today via a constant contact email message. So please check both your primary inbox and your spam box. And with that, I will wish everyone a wonderful afternoon, and thank you to Kimberly and Katie for your time today. Thanks, everyone.